you. And I'd really like to thank the Endocrine Society of India for such a wonderful seminar which you have organized. And specifically, my special thanks to Professor Jubin Jacob for inviting me to deliberate before this esteemed gathering. So this is a bit of my CV. So I've been allotted a very interesting topic, that is testosterone therapy in elderly patients with type 2 diabetes. Now, if I was allotted this topic maybe around 10, 15 years ago, everybody would have scoffed at this concept. What are you talking about testosterone in the elderly? They really don't have, or rather, in other words, they really don't need to bother about sexual dysfunctions, because in an elderly patient is something which is absolutely non-existent. But we have to realize that testosterone deficiency in elderly people not only means deficiency in sexual dysfunction, there are other issues as well. So with this background, let us start on the first case. This is actually a real life case who came to me. It's a 72-year-old retired McDonald, was a known diabetic for the last 10 years and having hypertension for the 18 years. The presenting complaint was just a worsening of body fatigue and weight loss over the last 18 months. And the medications, as you can see on the screen, glimepiride, metformin, and telmisartan, that's all he was on at the moment. There was no significant past medical history apart from a gunshot injury in his left thigh, sustained during a trance line of control action in Jammu. He denied any addiction apart from the regular whiskey of around 120 ml every evening. He was a non-smoker. Clinical examination, as you can see, his weight, height, reasonably okay. Waist circumference 75, which means that he certainly was not having any significant obesity. Blood pressure was normal with no postural drop. Examination was keen. It was very smooth with very scanty facial and body hair. So it was a soft skin, very scanty and facial body hair. And on questioning, he admitted that he was having a reduced frequency of shaving over the last 1 year. That means he needed to shave maybe once every week. There was no skin pigmentation. He looked a bit emaciated with wasting of limb muscles. Peripheral nerves on examination were normal. Clinical examination also revealed a scar mark of surgery in the left upper thigh very close to the groin. Systemic examination was absolutely unremarkable. So we did a sort of a routine battery of tests. We're trying to find out what exactly went wrong. You can see his diabetes control, not absolutely under control, but not too bad either. Lipids were normal. Some very early neuropathy, the vibration perception threshold was around 22 volts in both the lower limbs. Complete blood count was normal. Urea and electrolytes, that is sodium, potassium, creatinine was normal. KSH was normal. Cortisol was okay. LFT was normal. And other imaging investigations like chest X-ray, echocardiogram, and also the ECG, they were all within the normal limits. So we were just wondering what exactly could have happened to this gentleman. And then the leading information came from his wife. A bit reluctantly and a bit diffidently, she admitted, over the last 2 years, my husband has become thoroughly disinterested and he cannot sustain any erection, and that is causing him a lot of mental disturbance. So this was the statement from the lady. With this new piece of information, we did other things, including the examination of the genitalia. As we all appreciate, examination of the genitalia in anybody is a very private course, and not everybody would like to do that. But because we had this information, we could do it, and what we could find out was that his testicular volume was slightly reduced, he had sparse pubic hair. And on further examination, what we found out was that his testosterone level was significantly reduced. LH and prolactin were reasonably within the normal range. So basically, when we're dealing with type 2 diabetes plus old age plus a testosterone deficiency, what we're dealing on with is a late onset hypogonadism in a type 2 diabetes. Let us not forget the fact, the basic thing, which is very, very important to appreciate, is that as you grow old, your testosterone levels go down. And as you have diabetes, your testosterone levels also go down. It's a double whammy together. Now, this is sort of a classification of hypogonadism. I'd like to draw your attention to the areas marked in red. So when you're dealing with primary hypogonadism, we can have a late onset hypogonadism, which could be primarily because of a testicular failure. And also at the same time, there could be an idiopathic hypogonadism, which could also be present in elderly people. But if you look at the functional hypogonadism, that's the most important thing when we're dealing with diabetes. It's a known fact that two of these things, obesity and type 2 diabetes, they lead to a functional hypogonadism. Now, what we mean by the functional hypogonadism is that these patients that do not have any structural abnormality in the hypothalamo-pituitary testicular axis, And in fact, there is actually, I should not use the word not have any, there's got a very minimal changes here in the presence of diabetes. But again, we have got an elderly issue here. I mean, that means that in elderly people, there is also this issue of a testicular hypofunction. So these together, they leads to a reduced testosterone level in the blood. So what is the definition of late onset hypogonadism? It's a clinical and biochemical syndrome associated with advanced age and characterized by typical symptoms and a deficiency in serum testosterone level. This can result in a significant detriment to the quality of life and adversely affect the function of multiple organ systems. One of them has already been discussed about by my previous speaker, Dr. Third, and she has very beautifully alluded to the fact that testosterone deficiency can actually lead to a worsening of your cardiac function. Though again, as I'll go through my discussion, you will find out that this again is not an area completely rid of controversies. If you look at the incidence of late onset hypogonadism, we can see here from this graph that as you grow older, this hypogonadism is prevalent in more and more number of people. For example, when you're attaining the age of 8 years, nearly 91% people could be having a reduced testosterone level in the blood. However, in spite of the reduced testosterone level in aging men, only a small proportion of them develop the genuine syndrome associated with physical, sexual, and psychological symptoms. And from the EMAS study, which was basically the European male aging study, it showed that only 2% population between the age of 40 to 8 years had a late onset hypogonadism. As the symptoms and the biochemical testosterone deficiency, they do not often coexist in the same individual. And this is a very important thing that we have to bear in mind when we're dealing with hypogonadism. Now, what about this combination of hypogonadism and type 2 diabetes and obesity? This was again a sort of a table based on a very famous study published about 3 years ago, which looked at the proportion of diabetes patients in obese males and hypogonadism. As you can see here, hypogonadism plus obesity in this class of people, between 30 to 20% patients they had diabetes, and a significant number, between 30 to 40% of them, had suffered from testosterone deficiency. So approximately 20 to 64% of obese men, they've got a low serum testosterone, and between 40 to 80 years of age, the serum testosterone value in men with a BMI more than 30 is on the average 30% more than that of a man with a BMI less than 25. So we have got the plot actually thickening here. So we have got diabetes, we have got obesity coming in together at the same time, and we have got hypogonadism. All these three factors, they can go hand in hand. So when we're dealing with type 2 diabetes and hypogonadism, the elderly, what are the basic concepts of pathogenesis? So before we go into the pathogenesis, some of the basic things that has to be very, very clear about is that testosterone in blood is found mainly bound to the sex hormone binding globulin, around 45%, and albumin. The remaining remains as free testosterone. The testosterone bound to the SHBG is not biologically available. And the one bound to albumin is weakly bound and can dissociate to free and active testosterone. Total testosterone can be measured by radioimmunoassay, and the gold standard is liquid chromatography mass spectrometry in tandem, that is LCTM-MS. This is a gold standard, but not readily available. Free testosterone is measured by equilibrium dialysis. It's again a gold standard, but not readily available in many of the centers of India. And that's one of the reasons why in the sort of the guideline or the consensus guideline that we wrote about a few months ago, we recommended for going for total testosterone and SHBG as the two primary tests that look at the testosterone deficiency. And we also go by what is known as the free testosterone index. Now, whenever we're talking about the testosterone and SHBG, it is important to know what are the conditions which lead to an increase and decrease in the SHBG levels. So we can see that these two important issues, which are very important. I mean, SHBG can go down in many conditions, but for our discussion today, it is important to bear in mind that obesity and type 2 diabetes, both of them lead to a reduction of the sex hormone binding globulin. And that is one of the reasons for the functional hypogonadism that we find in diabetes. Again, SHBG can go up in aging. So what happens if the SHBG goes down? The reduction of SHBG can result in a low normal or a slightly below normal total testosterone value in a eugonadal man. Whereas in aging, the SHBG can actually go up, and this may result in a relatively normal testosterone concentration in men with hypogonadism. So we can well appreciate this is a very complex scenario, and to what extent this SHBG is going to play a role is very much multi-etiology, multifactorial thing. So if you're looking at the pathology of late onset hypogonadism, what happens is basically there's a reduction in the gonadotrophin release of hormone pulse and pitch amplitude and attenuation of the diurnal pulsatility of this gonadotrophin release hormone. This leads to a reduced hypothalamic pituitary gonadal feedback axis due to low testosterone. And because of this, there's a frequency of reduced frequency of the large amplitude LH pulses. On the testes also, what happens, the changes that take place because of the aging, there is a reduced Leydig cell number, impaired Leydig cell function, and reduced LH feed-forward activity on testosterone secretion. So that means not only is the testis producing a lesser amount of testosterone, but in conjunction with a high SHBG, it is leading to what is known as apparently normal testosterone levels. But again, LH response to such a reduced testosterone is much, much reduced. And this is something which again contributes to a reduced spermatogenesis. Now let us look at what happens in the presence of type 2 diabetes. So we can see here in type 2 diabetes, one of two important facts associated with type 2 diabetes are increased insulin resistance, obesity, and obesity leads to an increased production of estrogens, which again leads to a reduction in the gonadotrophin release hormone secretion. And at the same time, diabetes leads to an inflammatory markers, that is increased levels of TNF alpha, interleukin 1 beta, IL-6. This again contributes to a reduced gonadotrophin release hormone secretion. And this reduced gonadotrophin release hormone secretion is also further facilitated by reduced leptin and insulin signaling in the CNS, that is hypothalamic pituitary pathway. It's actually a very complex procedure. I've put forward this graph just to make sure it's very simplified. So this actually leads to a reduced action of leptin on the Leydig cells, leading to a reduced testosterone secretion and a reduction of testosterone. And again, the reduced gonadotrophin release hormone secretion leads to reduced FS secretion and reduced spermatogenesis. So this, in brief, is exactly the way of pathogenesis of hypogonadism in the presence of type 2 diabetes. Now, a few salient points to bear in mind is the fact that functional hypogonadism defined as subnormal testosterone value with low or inappropriately normal gonadotrophins and no organic defect in the hypothalamic pituitary region is common in men with type 2 diabetes. And functional hypogonadism in men with type 2 diabetes is a result of multiple complex interactions, as I've shown in the previous slide, between the multiple factors including the old age, visceral obesity, insulin resistance, serum, SHBG, leptin, and other inflammatory markers. How do you clinically diagnose hypogonadism in elderly people? The core symptoms again are erectile dysfunction, reduced frequency of early morning erection, low sexual desire, and reduced frequency of sexual thoughts. So these are the core symptoms. If these core symptoms are not present, you should really think it 2 times before diagnosing hypogonadism in an elderly type. Some other secondary symptoms which may coexist and as existed in Mr. Banerjee: easy fatigability, poor concentration, depression, disturbed sleep rhythm, decrease in initiative, motivation, energy, and self-confidence, and reduced muscle strength. As we all know, this was also talked about by Dr. Thur in her previous presentation, that this is something which does improve with testosterone replacement. And as the degree of deficiency goes by, we can see that we start the minimal testosterone deficiencies, the present with a decreased libido, decreased vitality, and a loss of facial and axial and pubic hair. That is something which happens when there is a profound testosterone deficiency. So what is the laboratory diagnosis protocol? Whom should we evaluate for testosterone deficiency? It is typically indicated in elderly men with type 2 diabetes with 1 or more core symptoms of testosterone, that is reduced sexual thoughts, reduced sexual drive, and reduced early morning penile tumescence and erectile dysfunction. If none of these histories are present, you should think twice about seriously considering hypogonadism in an elderly people. There's no measurement of serum testosterone in patients with non-specific symptoms, in the absence of core symptoms, and there is absolutely no role of routine measurement in all elderly type 2 diabetes patients because it does not really alter your management. This is a protocol how you go for an assessment of hypogonadism in elderly and type 2 diabetes patients. So the blood ideally should be collected at around 9 a.m. or between 7 to 11 a.m. If you cannot do that, you should collect the blood within 3 hours of waking. It's acceptable. It's particularly important for elderly gentlemen who have got a very disturbed night's sleep and maybe getting up late at around 9 or 10 in the morning. So you just collect the blood 3 hours after the patient is woken. And then you look at the serum testosterone level. If it is low, you reconfirm it and find out whether FSH and LH is higher or lower. If it is lower, inappropriately normal, then we're dealing with a fine functional hypogonadism. And in that situation, again, we have to look for whether the patient has got a functional or an organic hypogonadism. And if the patient wants fertility treatment or an organic secondary hypogonadism, this patient should be referred to an endocrinologist for evaluation. If the patient is just got functional hypogonadism, does not want a fertility treatment, this patient can be considered for testosterone replacement therapy by a physician. Obviously, must be under the care of an endocrinologist. And obviously, if the patient has got a borderline serum testosterone, you have to reevaluate it. And why we'll be discussing just in a few time. Normal serum testosterone levels, forget about the late onset hypogonadism or diabetes and hypertension. So the diagnostic criteria is less than 2.3 nanograms per ml of serum testosterone, or where indicated free testosterone less than 46. Total testosterone more than 3.5 completely rules out testosterone. Now, specific issues is that bioavailable free testosterone should be measured only when serum total testosterone concentration is not diagnostic in symptomatic individuals, for example, in obese men. And we have to remember something, that transient decrease in testosterone levels occur during acute illness. So no testing should be done when the patient has just recovered from acute illness, at least not in the first 3 to 4 weeks after the patient has recovered from the acute illness. And weekly variations in testosterone levels occur, so people having an ambiguous value between 2.3 to 3.5 should have a repeat testosterone assay, which may be done. If the serum testosterone level is less than 1.5, we have to seriously think about an organic hypogonadism, and we have to go for a detailed pituitary hypothalamic workup, including measurement of the serum prolactin and pituitary imaging.
Sir,
Hypothyroidism.
Sorry to interrupt you, sir. You have 2 more minutes, sir. We are
I'll just
short
finish
of
up
time.
within, it won't take very long.
Yes, sir.
Hypothyroidism should be excluded in all patients. So what about the management? So basically, you have to confirm diagnosis and effective treatment of underlying comorbidities like diabetes, obesity, and hypertension is mandatory before considering testosterone replacement therapy. Testosterone replacement therapy remains a treatment of choice in proven late onset hypogonadism in the absence of contraindications like unstable cardiovascular. So lifestyle modification, it has been shown that weight loss is able to increase the testosterone levels proportionately related to the amount of the reduction in body weight. And this weight loss dependent increase in sex hormone binding globulin, calculated free testosterone, LH, and FSH. And there's also a significant reduction in the estradiol level with body weight reduction. Now comes the $1 million question, and this is something which has come to the notice in the last couple of months. Can testosterone replacement prevent diabetes progression or reverse the type of diabetes? In June this year, the T4DM study was published, and this is basically based on certain concepts which we are all familiar with. There's men with low testosterone have an increased insulin resistance, and which is one of the root causes of diabetes management of type 2 diabetes. Testosterone replacement for 2 years significantly reduced the visceral fat, increase the muscle mass, and reduce the risk of incident type 2 diabetes, and may also reverse type 2, as this particular slide will show. Basically, that patients in whom testosterone was given for preventing type 2 diabetes, that is having high risk pre-diabetes at baseline, or reversing diabetes. And what we can see here, there is a significant change in the response to testosterone therapy between the two groups. One group which had the testosterone replacement, and the other group did not have any testosterone. We can see here, there is a significant difference of a significant degree of improvement in both prevention as well as reversing type 2 diabetes with testosterone replacement therapy. Not only that, there is another very interesting concept which I'd like to introduce. This is about the accuracy of HbA1c in the presence of hypogonadism. HbA1c is not only linearly related to blood glucose, but also has to reduce lifespan. So if at any average blood glucose level, a reduced RBC lifespan leads to reduced HbA1c, and an increased RBC lifespan leads to an increased HbA1c. If you've got a hypogonadism, your RBC lifespan is reduced, and curiously, the HbA1c levels are reduced. And testosterone replacement leads to an increased RBC lifespan, increased HbA1c. Now, this could be one of the reasons why all the previous studies which looked at the effects of testosterone replacement on anthropometric and glycemic parameters in men with type 2 diabetes, it showed extremely variable results. Some of them showed benefits, some of them did. This could be because of the effect of hypogonadism on the incident HbA1c. So basically, testosterone replacement therapy, as we told you, these are the indications, as you can see. It should not be given for patients with treatment with depression and with diabetes. And there are controversial outcomes in the presence of pulmonary artery disease. They should be avoided if PCB or the packed cell volume hematocrit is more than 48%, and in the presence of a frank prostatic carcinoma, frank male breast carcinoma, and if the PSA is more than 4 nanograms per ml. So these are the different preparations of testosterone which you can use. These are the pros and cons. Obviously, the commonest ones and one of the best studied ones are the parenteral intramuscular ones, particularly the testosterone undecanoate. Unfortunately, there have been some studies, some even good results with the transdermal patches. But again, in a tropical country like India, I'm not sure how much it's beneficial for the simple reason because the transdermal patches, they tend to lose their effectiveness, but there is an excessive sweating. And this is how you
Sir,
evaluate.
can you summarize and conclude?
Yeah, I'm just going on to the last step, but just 2 more slides
Okay.
left. So this is how you evaluate for the testosterone replacement. So you monitor it 3 to 6 months with the injectable. And these are a detailed way how you assess for the replacements. And how long to wait and when to stop. So basically assess for the testosterone levels at baseline at 3 months for erectile dysfunction. For the libido, around between 3 to 6 to 12 months. And you monitor for the hazards. You stop with the PCB is more than 48. If the PSA is more than 1.4 nanograms per ml, increase within the 12 months. Lastly, also, if there's a significant worsening, lower infection. So Mr. Banerjee was started on testosterone undecanoate and symptomatic improvement was noted in around 4 months. And there was also significant reduction of HbA1s with the further optimization of the glucose. So the final take-home message, and my apologies for being a bit too prolonged. In elderly type 2 diabetes, testosterone deficiency is uncommon, but you must have an open mind when to diagnose and when to treat such patients. And a proper evaluation of the clinical and biochemical parameters along with risk stratification is necessary before contemplating a testosterone replacement therapy in an elderly gentleman. And with periodic monitoring, testosterone replacement can be helpful in elderly type 2 diabetes. Thank you very much. I am my presentation.